much for your kind introduction, Prof. Wan, and thank you for the invitation to participate and give you some current understanding and perspectives of SGLT2 inhibitors in Ramadan fasting. So as a very in a short period of 15 minutes, I briefly want to take you through these areas, particularly looking at SGLT2 inhibitors and their safety, and therefore, especially during Ramadan fasting, there are earlier studies and some recent studies that have been published, and there are current recommendations from the most recent edition of the IDF-DA guidelines, which I will mention as well, and also refer to the DA 2020 global survey, some data of SGLT2 inhibitors, as well as a brief glimpse at the DA 2022 combined with 2020 global survey, also giving you some data on SGLT2 inhibitor use. So I think we don't need to go through to detail, but we understand, and it's important because SGLT2 inhibitors do actually work through the kidney, as we know, and does promote diuresis and potentially hypovolemia because of the fluid loss and fluid deprivation. So we understand that in Ramadan there is abnormal pathophysiology of glucose and lipids. There is, in fact, Ramadan fasting is said to be a state of insulin resistance. There is, in fact, shown hormonal changes such as hypercortisolemia, particularly in the evening, and increased insulin resistance. But also Ramadan is a state of insulin deficiency as well. And together with this, we know that there would be increased glycogen breakdown and increased gluconeogenesis in both type 1 and type 2 diabetics, making them prone to ketogenesis, particularly in type 1 diabetes. And this is also accompanied by the increased lipid or fat oxidation. And all the prior speakers this afternoon and evening have already highlighted the well-known risks of Ramadan fasting, which are the extremes of glycemia, both hypo and hyperglycemia, with an increased risk of DKA. And this is particularly of concern with the use of SGLT2 inhibitors, as we are well aware that they can actually cause both ketosis, and also, of course, dehydration because of the osmotic diuresis and glycosuria, and also with this, the threat of thrombosis. Also has been highlighted by the previous speakers. Always, we do not fail to mention the data from the EPIDIA study, which is already 2 decades old already. Initially, then, as highlighted by Dr. Khatija before in the prior lecture about the increased use of the older insulins and probably more so sulfonylureas in that time where there were less or no of the newer agents that we now use that are less risk of hypo. And we acknowledge that both in type 1 and even type 2 diabetes, there's increase in risk of hypoglycemia in the EPIDIA. As we can see here, it quotes in type 2 even a more than 7-fold increase in severe hypos. And along with that, in the other extreme, with hyperglycemia, a 5-fold increase in fact, ketoacidosis reported in the EPIDIA study, with increased hospitalizations for both hypo and hyperglycemia. So in fact, with the use of SGLT2 inhibitors, we may in fact see less of hypoglycemia because it does not is not insulin mediated in its use, but we may see in fact what we want to know is whether there's increase in fact ketosis and dehydration, which is the other concern of Ramadan because of the fluid restriction during the fasting period. And it's already been shown that those who are fast would be at risk of orthostatic hypotension or postural hypotension. All right. So in the DA Type 2 Diabetes Global Survey 2020, which we published in 2021, we also showed that 2 decades later, after EPIDIA, there is still a substantial risk of hypo and hyperglycemia in Type 2 diabetics. And overall, 1 in 6 of Type 2 diabetics in the study, either way, would have hypo or hyperglycemia. And put together, this is a threat for up to 1 in 3 persons with type 2 diabetes fasting in Ramadan during the global survey, having a risk of either one. And there is, of course, that increased risk in those in the older age group, as I had mentioned before in previous session that the age and duration of illness play a part in increasing the risk of the complications. We've also heard at length about the risk scoring during the latest risk scoring as recommended by the IDF-DAR Practical Guidelines 2021, and I'm not going to go through it in any detail, but just to highlight that the type of treatment, because we're talking about types of treatment in this session, does play make an impact, and you can see that what gives most contribution to the risk scoring is in fact drugs that cause increased hypo, such as insulin and sulfonylureas. And other than that, in fact, the drugs, for example, as we are concerned with the newer drugs such as SGLT2 inhibitors and the other incretin incretin-based therapies, in fact, do not contribute to an increased risk if we're just looking at them independently, as mentioned in the IDF-DAR guidelines. So I think all of us are really well aware. We've had the SGLT2 inhibitors as glucose-lowering drugs initially since it's been 10 years, it's been a decade in fact, and we recognize that they really are good drugs to lower glucose moderately in terms of lowering HbA1c. And with that, what we want of a glucose-lowering drug is also to reduce body weight and in fact do not increase risk of hypoglycemia. And in fact, other important sort of benefits such as improving blood pressure as well. After that, with the publications of the landmark clinical trials of cardiovascular outcome trials and later heart failure outcome trials, we recognize that the benefits of these drugs are beyond glycemic lowering or glycemic control, but also the cardioprotective benefits. And then in the recent couple of years or so with the publication and presentations of the renal outcome trials for the different SGLT2 inhibitors, we also understand their protective benefits for renal endpoints and renal mortality. So in fact, if we're really looking at the most favorable glucose lowering drug, and this is a chart taken from our type 2 diabetes CPG, Malaysian CPG in 2020, we can see that the SGLT2 inhibitor class is the one that presents the most favorable in terms of the less risks of hypo, in fact giving favorable weight reduction, no added increase in symptoms of the GI, and benefits in both cardio and renal, as mentioned before. And of course, patients fasting in Ramadan should continue to benefit from this medication as well. So in terms of safety of SGLT2 inhibitors, we have recently published in the last few months a paper looking at specifically in the Asian cohort, the safety of SGLT2 inhibitors use. And of course, we know the increased risk of genital tract infections. And if we can see in this chart, that in the Asian population, it's quite low, in fact, reported for dapagliflozin and empagliflozin rates of between only 2 to 4% of genital tract infections, and even much less for urinary tract infections. This may or may not present an issue in the Ramadan period, and we are already aware of the appropriate counseling and management of these patients if they do have these complications. I will present the other more important adverse events of concern in Ramadan, but the conclusion of this paper is that the SGLT2 inhibitors are generally safe, and the adverse effects, particularly in Asian patients, are reasonably low, and we would still resort to the appropriate patient counseling and proper selection of patients to ensure safe use and effective use of SGLT2 inhibitors in type 2 diabetes management. So if we're looking at the concerns in Ramadan, and specifically what we can see here is that for volume depletion in the Asian patient, there are data that are reported, and you could refer to our paper for canagliflozin, dapagliflozin, empagliflozin, that none reported for dapagliflozin and none reported for lusiogliflozin, which is SGLT2 inhibitor from Japan. And the rates are very low, as you can appreciate here. For volume depletion, EMPA is about 4 to 5%. CANA reported even lower at 0.4%. There is, of course, in the table in the paper, a particular highlight that adequate fluid intake should be taken, and a fasting period, as we know, is highlighted here, and therefore patients on SGLT2 inhibitor are actually advised to catch up on their fluid intake in the non-fasting or after breaking of fast. For acute kidney injury, we've heard about that just now from the prior session. For the Asian data, there's been some reports of acute kidney injury, and they are again low, as you can appreciate that for the different SGLT2 inhibitors here from DAPA, EMPA, and lusiogliflozin, spanning about 1% to 5% to 7%, as you can see in this table. And the appropriate concerns that have been mentioned by the prior speakers about, assessing renal function prior to initiating SGLT2 and monitoring, as well as caution with loop diuretic use concomitantly, is again highlighted here. And the other aspects of safety, which are hypoglycemia and DKA, again a particular concern in Ramadan, are also highlighted in our paper of safety of SGLT2 inhibitors in Asian patients. Again, reporting very low use of hypos, as can mention here. And also here, it highlights the study done in Ramadan, which I will particularly mention later. So these are some safety data, including the DKA data that is mentioned, which is actually also quite low here. But this is in general, spanning across different, not specifically in the context of Ramadan. Right. So in the context of Ramadan itself, there have been SGLT2 inhibitor studies, and this has been well presented and illustrated in the recent IDF-DA guidelines. And I've just actually summarized this from the DA guidelines 2021. And these were the 5 different studies on specifically DAPA, CANA, gliflozin, which was available prior to the publication of the DA guidelines, because prior to that, there was some concern about the use, and even the Canadian guidelines in 2016 did put a caution on the use of SGLT2 inhibitors during Ramadan, and in fact restricted its use. But following these studies, which actually, as you can see here, studies which were published after that, 2016 and a year later, and subsequently 2018 and 2019, from Malaysia, from the UAE and the Middle East, as well as from Singapore, with different cohorts, looking at SGLT2 inhibitors, in some comparing with SU. Definitely the rates of hypoglycemia when using SGLT2 inhibitor are far, far lower than when compared to the use of sulfonylureas, and this is quite evident. When looking at other concerns, particularly dehydration and fluid balance or fluid loss, there were, as mentioned, some concerns about postural hypotension, and that is more evident in the SGLT2 inhibitor group if it's compared to the comparator SU, as you can see in both the first 2 studies mentioned here with dapagliflozin and canagliflozin. But subsequent to this, what was then mentioned in the recommendations is that it should be safe to use. In the DA Global Survey 2020, SGLT2 inhibitors were also studied. And you can see here, we reported the findings of the DA 2020 Global Survey, and we can see in the diabetic medication section the spread or distribution of prescription of drugs in those patients with type 2 diabetes fasting in Ramadan in the overall group, and of course in this paper specifically looking at the less 65 and above 65. But I'm here to highlight to you the use of SGLT2 inhibitor then was about 14% of the entire cohort, with a lesser proportion of use in those elderly for reasons we would comprehend. And the overall use was probably 1 in 7 individuals. Yes, so quite a small, sort of quite a good use, but maybe if we think about it, we would expect a higher use by now. Yeah. So just looking at the data before, the 3 SGLT2 inhibitors that were prescribed, we have data on during the DARG 2020 survey. Most was prescribed in 2/3 of patients was empagliflozin, followed by dapagliflozin, with only a very, very minimal use of canagliflozin in about 800 plus patients in the DARG 2020 survey. Yeah. Most patients were on combination of drugs, so it may be difficult to actually allude, to the drug specifically in terms of whether it causes increased rates or decreased rates of breaking of fast. But just a simple look, the rates of breaking of fast in SGLT2 inhibitor patients were much lower than SU and insulin patients, as we would expect. Maybe they were not using it mostly with a combination. Yeah, but we have more data in the combined group. So anyway, after those results, the DAR 2021 practical guide did have certain recommendations. This was in the chapter 10, which actually looked through anti-glucose lowering medications and made specific recommendations for SGLT2 inhibitors, which we are familiar with and which we all, I'm sure, follow. Basically, they have low risk of hypoglycemia was the main, sort of take-home message, and there's no need to do any dose adjustments during Ramadan. There is understanding that it should best be initiated prior to Ramadan and not during Ramadan, and this has become standard practice, and best to be administered after iftar. There is at that time an indication to start on a lower dose if it was mainly for CV or renal protection. Yeah, and as mentioned, to be particular about keeping up to fluid intake in the non-fasting hours, and actually not requiring any treatment modifications specifically, but the other drugs that are prescribed together with it, maybe SUs and insulins, may need to be actually adjusted because of the possible risk of hypoglycemia. Yeah, so I would just want to actually briefly look in the next 2 slides on 2 recent studies published this year, and again give us more data to actually sort of confirm or to actually reassure us about the safety of SGLT2 inhibitors. And in this time, what we didn't have before is the empagliflozin sort of safety data. And we have a publication from Bangladesh recently of a 6-month multi-center open label parallel group 2-arm survey, which was prospective. As you can see here, looking at, about almost 500 patients on empagliflozin with metformin plus minus DPP4 inhibitor or without empagliflozin, and looking at the different endpoints, efficacy endpoints such as A1C reduction and other safety endpoints like hypoglycemia and changes of blood pressure and indices of renal function. And here in the table, you can actually appreciate the A1Cs in the EMPA group and the non-EMPA group and the changes that occur following Ramadan. This is a prospective trial, and also actually the baseline, if you can see here, that they are diabetics with a duration of illness of about 7 years and an A1C of about 8% and a bit, yeah. And actually could improve their A1C, in fact, when they were on empagliflozin as compared to the non-empagliflozin group, yeah, and actually had some weight reduction as well, yeah, and their BP as well showed some improvement compared to the non-EMPA group, yeah. And also the safety parameters were looked at, and there was no increased risk of hypoglycemia. So the conclusion from the study from Bangladesh was that the treatment of adults with type 2 diabetes with empagliflozin showed efficacy and safety in Ramadan with no increased risk in hypoglycemia and hypovolemia compared to those that were not on EMPA, and they were also on metformin with or without DPP4 inhibitor, and therefore continuing these drugs, because these drugs were already on well established in the patients for at least 3 months prior to Ramadan, continuing it would be safe. Yeah. And the second study is a Malaysian study, which was also recently published, also a prospective cohort study, again with empagliflozin, and specifically just looking at safety endpoints of particularly looking at dehydration, changes in renal indices, and particularly also ketonemia and ketosis, and also using a self-reported hypoglycemia scoring to look at hypo incidence. And these were patients that were having diabetes. What was significant in terms of the difference between the groups on EMPA and control was the group on EMPA had definitely longer duration of illness, and a little bit more in proportion of hyperlipidemia, but their A1Cs were about similar in the 8% and above range. Well, what was found is there was no difference in the urea, creatinine, EGFR, hemoglobin or hematocrit between the empagliflozin group and the control. And there was a reduction in weight and BMI in both groups, with a significant reduction in the waist circumference. Yeah. Blood ketone levels were higher in the empagliflozin group, as you can see figures here, but they were not statistically significant. And ketonemia only occurred in about 4 patients in the empagliflozin group, and none of the patients required a discontinuation of the SGLT2 inhibitor of concern, as they were quite well. And there were no admissions for DKA, and hypoglycemia episodes were actually comparable and not statistically significant between the two groups. Yeah, and therefore the similar conclusion, and again providing us more reassurance that the SGLT2 inhibitor, particularly empagliflozin during Ramadan, was found to be safe in these smaller cohort of type 2 diabetes, with no increased risk of dehydration, acute kidney injury, ketosis, or hypoglycemia. So just before I end, a very, very brief look at the DAR Global Survey combined group of 2020 and 2022. And we were most impressed with the numbers, which have gone beyond 12,000 individuals, more than 66,000 in the 2022 survey, and also almost 6,000 in the 2020 survey. And the rates of SGLT2 use in the now is up to almost 1 in 5 subjects, which is 19%, as had been mentioned earlier in the beginning session. Yeah, and you can have a nice comparison of it. It is still sort of behind DPP4 inhibitors and behind sulfonylureas in terms of oral glucose-lowering drugs. But very interestingly, when analyzing the SGLT2 inhibitor use into 4 different categories, whether they used it in combination with other drugs, with or without SU, with or without insulin. Here are the actual data that you can see, and might be a bit difficult to interpret all the figures, but I've sort of shaded the insulin, the rows on insulin, and what we can appreciate is that there's some, a high use of SGLT2 inhibitors of about, 40% of the use, when it's being used, is used together with insulin, but not with SU. The A1Cs at mean in those, of course, on insulin are actually higher, and as expected, their duration of illness higher, probably characterizing more patients with more complex, more comorbids, more complications. And it's definitely true. I don't have the opportunity to show you the actual spread of comorbidities, but it is much higher in those with insulin. And as you can see, the rates of nephropathy and macrovascular disease, nephropathy here is both microalbuminuria or an elevated abnormal EGFR, is higher in those in using SGLT2 inhibitors together with insulin. But it is, again, appropriate that these drugs are used in patients with cardiorenal sort of pathology because of its possibility of protecting these type 2 patients from the morbidity and mortality in this direction. So I hope that we can actually further analyze the SGLT2 inhibitor data for the combined group. I'm sure we will be able to present that later. As a very brief summary, we can see that SGLT2 inhibitors in the DAR Global Survey almost equally used a little bit more so without insulin. 54% are used without insulin, and about 46% are used with insulin, with or without SU. Important to highlight that the hypo and hyperglycemia rates, as you can appreciate here, are much higher when it's used with insulin as opposed to without insulin. And also, as mentioned before, the trend of having a higher A1C, longer duration of diabetes, nephropathy, and macrovascular disease in those with SGLT2 inhibitors and insulin. So as a conclusion, ladies and gentlemen, the use of SGLT2 inhibitors has been consistently, with this recent data, found to be safe and effective during Ramadan fasting in the recent studies, and confirming the safety of use. And we would expect an increasing use of SGLT2 inhibitor as seen in the recent few years and in the future, especially with the landmark cardiovascular renal outcome trials that have shown its remarkable cardiorenal protective effects, including a reduced mortality, in fact. And with the DAR Global Survey 2020 and 2022 combined data, we have a better understanding of the recent pattern of use of SGLT2 inhibitors in type 2 diabetes patients during Ramadan fasting. And we feel they are appropriately used as seen in those with renal and cardiovascular disease. However, if we look at the rates, 19%, 1 in 5, in keeping with the understanding that there's high rates of comorbidities and complications, it is still a relatively underprescribed sort of class of agent. Hopefully, more patients will be more accessible to its use. And so it also is interesting to see that there are substantial, about half of the patients in the global survey combined are using the drug earlier before insulin is initiated. So with that, thank you very much for listening. Thank you, and I'll stop sharing my slides.